Specialized Society of Pediatric Neurology for inviting me to speak today. It's a great honor to be here. I never thought, though, I would be cold in Cairo, and I've been sitting there waiting to come up. So I'm briefly going to talk about developmental brain maturation, and then how there's an increased propensity for synchronization of neuronal activity, and that's demonstrated by age-dependent clinical syndromes, and then talk a little bit about particular seizure subtypes and the difference with adults. So there are some observations about the immature brain. The incidence of seizures is higher in early life, as Dr. Abdel-Moati showed us, and the seizure burden can be significant, and it can result in long-term sequelae. And the immature networks show a high capacity for excitability, and as we'll see, synchronicity. But immature neurons are less vulnerable to insults, including HIE and seizures. And that leads us to conclude that there must be more than one of the mechanisms preventing excess activity in adults, which is not present earlier on, and that seizures produce their consequences by altering fundamental processes, not simply by neuronal injury. This slide shows the stages of activity-dependent brain development. And you can see that you start off down here with proliferation, and then it moves on to growth and synapse formation and network formation, such that by the end, you're talking about 10 to the 15 synapses. This process can be influenced by genetic factors and the environment, as shown here, held in the balance by our baby in the corner. These processes are activity dependent, and it's easy to see why certain genetic or environmental insults might cause aberrant pathways or maturational processes to evolve during this process. This graph shows the developmental course of the brain from preconception to adulthood. You can see that early on, and where Dr. Abdel-Moati was talking about is down here, okay, neonatal. But you can see that from birth, there is a rapid proliferative phase of development, which starts in the sensory motor cortex, then moves to the parietal and temporal, and lastly, the prefrontal cortex. You can see that during the proliferative phase, there's the potential for increased excitability and synchronization, and certain techniques of connectivity analysis indicate that there's a shift from diffuse local functional connectivity in children to much more focal patterns of functional connectivity in adults. When we superimpose on this graph our clinical observations that an adult seizure semiology is unlikely to be seen before the age of 6, we can see that this coincides with the later phase of rationalization and synaptic pruning that occurs beyond the age of 6. So moving on then to talk about some examples. Infantile epileptic spasms, the new terminology for West syndrome. My trainees remind me when I drift off into the old terminology that this is now what it's supposed to be called. And what about epileptic spasms in general? They have unique characteristics. They are brief axial and limb contractions lasting less than a second. There's ictal EEG slow wave transient, followed by an attenuation period. Infantile epileptic spasm syndrome, or West syndrome, typically has an interictal EEG with hypsarrhythmia, although we know there can be variants and modified versions of that. And spasms are obligatory in infantile epileptic spasm syndrome, includes in the name, but they also occur in other syndromes, such as Ohtahara and later on Lennox-Gastaut syndrome. So the term epileptic spasms is now preferred to describe what we see rather than infantile spasms. There was a paper in 2015 which reviewed the 24-hour EEG and video for 161 patients under the age of 18 who were suffering from epileptic spasms. They were divided into 3 groups according to the EEG background. Group A, highly disorganized hypsarrhythmia. Group B, moderately disorganized but not reaching the criteria for hypsarrhythmia. And Group C, mildly disorganized, lower voltage and not consistent with hypsarrhythmia. They also divided the population into 2 age groups, less than a year of age and greater than a year of age. And in the results, the first thing that we notice in this red column here is that in Group A, who, if you remember, are the hypsarrhythmic group, those under a year of age, 68 out of 70 demonstrated that pattern. Looking at it the other way in terms of age, and we're looking at this blue row here, under the age of 12, greater than the age of 12 months, you can see that there is a greater migration towards having a Group C EEG, which is only mildly disorganized. There was no differences in etiology between the groups. They also looked at the spasm semiology and found some differences. You can see on this slide that in Group 1, in those less than a year of age, there was more involvement of the arms and legs. And later on, in Group 2, greater than a year, there was more involvement of the head. So what are the differences between epileptic spasms with hypsarrhythmia and epilepsies in older individuals? And they found several non-distinguishing features: etiology, ictal EEG, EEG, stereotypy of the spasms, the number of clusters a day, the number of seizures per cluster. None of these were distinguishing features. Just to give an example, let's see if I have the same. How do I start the video on this view? So there, and then I try and point at it, and it's a bit difficult. Yes, I know. So, oh, it actually works. Right, so let's just watch this. Okay. And I think this shows some of the features that Dr. Abdul-Moyati and one of the questioners were mentioning, that spasms come in a variety of shapes and sizes, but you can see that there's a generalized discharge followed by a slow wave, followed by a period of attenuation. I don't think anyone would dispute that that is a generalized ictal pattern in this case. The interictal EEG, however, does show discharges. There's some asymmetry in the discharges, and you can see that they appear to be more left-sided than right-sided. So keep that in your mind. And then in sleep, we go back to a generalized, more burst suppression-like pattern. So as for the cause, it was a right-sided DNET. Okay, so that's an example of a focal etiology presenting with some generalized features and actually the wrong side on the EEG. So focal epilepsies and generalized manifestations. They can present with epilepsy with focal onset can present with generalized characteristics, as we've just seen here. They can be clinical, they can be electrophysiological. The cause can be lesional, age-related syndrome, a genetic cause, an iatrogenic cause. And I'm sure we've all seen cases where carbamazepine has brought about a more generalized, often sleep-activated syndrome that we don't wish to see, and we'll talk about a bit later on. And why is this important? Well, it's important because an accurate diagnosis of the etiology can give you a prognosis, and it also has implications for management and the options available to you. Well, what is a seizure? Just to remind ourselves of the latest definition, because they can change over time, as we know from the ILAE. It's a transient occurrence of signs and/or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. That's the latest one from 2017. Manifestations of certain seizures are age-specific, and they depend on maturation. Previously, seizure classifications were based on anatomy. It's a temporal lobe seizure. It's an occipital lobe seizure, etc. But modern research has given us a bit more information about the pathophysiological mechanisms, suggesting that epilepsy is a network disease, and it isn't only a symptom of a local brain abnormality. Here's another example. I shall try to control my own mouse on this occasion. Here we go. This young lady, who's of 16, has a de novo DEC5 mutation. They can be autosomal dominant mutations which cause familial focal epilepsy with variable foci. She had an onset of epileptic spasms at 2 years, 8 months, which persist. And at 9 years, 5 months, her EEG showed background slowing and interictal left central sharp and slow wave runs and some frontotemporal delta. The generalized spike wave, which was also there, also had a left-sided temporal lead into it. Ictal EEG with spasms showed polyphasic rhythmic 2 Hz delta, which was maximal in the midline with some superimposed fast beta, and she had a normal MRI. However, a hypothesis-driven left-sided etiology was used to offer surgery, because we know that some children with DEC5 mutations can have cortical dysplasias. So based on that hypothesis, a left lateral temporal corticectomy was performed, but there was normal histopathology, and following surgery, there was no improvement. A recent paper in 2015 showed that epileptic spasms are a feature of DEC5 mTORopathy. There were 6 patients, from 5 families with spasms and DEC5 variants, 2 de novo, 3 familial, 2 with focal cortical dysplasia, and the clinical outcome was highly variable. Familial focal epilepsy with variable foci is characterized by seizures arising from different cortical regions in different family members, with onset from infancy to adulthood, so very variable. Families may show patterns that are phenotypically homogeneous. So in some families, you may see a pattern of autosomal dominant frontal lobe epilepsy. In others, you might see CELEX, the new terminology for Beck's or KEX, childhood epilepsy with centrotemporal spikes. Various brain malformations have also been reported. And this diagram shows the mTOR pathway with all its complications. And DEC5 sits up here as part of the GATOR1 complex. And that's a negative regulator of the mammalian target of rapamycin, the mTOR pathway. And it has brain-specific roles, including the regulation of synaptic plasticity and learning, neurogenesis, and dendritic and axonal morphology. And we know that other malformations of cortical development are due to abnormal neuronal and glial proliferation caused by aberrant activation of mTOR, don't we? Because sitting over here is our old friend, tuberous sclerosis, TSC1, TSC2, which encodes two interacting inhibitors of mTOR1, but also results in infantile spasms. So could we have a convergence of phenotypes in terms of mTORopathies? So some types of mTOR-related dysregulation could inhibit, potentially, given the functions, this shift from the diffuse local functional connectivity in childhood to more focal patterns of functional connectivity in adulthood. And could that inhibition in that maturational shift be responsible for persisting spasms? Coming back to the other paper with the non-distinguishing features, the distinguishing features they found between epileptic spasms with hypsarrhythmia and epilepsies in older individuals were, the distinguishing features were the amplitude of the interictal EEG, the defining feature of hypsarrhythmia, which decreased with increasing age, and the greater involvement of the arms and legs compared with the head. And this could reflect the high excitability and synchronicity in the immature brain as compared to the adult brain or the brain of the older children over 6. When you look at age-dependent epileptic encephalopathies with spasms, you can see that early on we have the early infantile developmental and epileptic encephalopathy down here in the blue. We then have West syndrome in old terminology in red, and we have Lennox-Gastaut syndrome in green. And when you look at the EEGs associated with those syndromes, you go from burst suppression to hypsarrhythmia to high amplitude slow spike wave. And could this represent a maturational, at least some maturational factors that are occurring, that are modifying the EEG, but yet we are still seeing the phenotype? The next example I wanted to talk about was the developmental epileptic encephalopathy with sleep. Thank you. Again, the new terminology used to be called CSWS, ESES, and part of that Landau-Kleffner syndrome. And that's a spectrum of conditions as well, with combinations of cognitive, language, and behavioral motor regression associated with marked spike wave activation in sleep. You normally see regression within weeks of the EEG pattern, and they share similar clinical features. The developmental epileptic encephalopathy version will be children who have developmental problems prior to the onset of the epileptic encephalopathy, whereas those with normal cognition will be called epileptic encephalopathy with activation of during sleep. So the similar features, of course, we all know: auditory agnosia, global regression of behavior and motor skills, and sometimes negative myoclonus, which you used to see in the old terminology, atypical, partial, benign partial, epilepsy of childhood. So this terminology does replace CSWS, atypical benign partial epilepsy, with the negative myoclonus, you could sometimes see. But the Landau-Kleffner syndrome is a specific type of epileptic encephalopathy with spike wave activation and sleep, with mainly language regression, with a marked acquired auditory agnosia, which if you've seen, you don't forget. So the eponym is being retained for that particular constellation of features. So it's an age-related epileptic encephalopathy, onset 4 to 12 years, with seizures and neurocognitive regression. The EEG shows slow spike and wave sleep in non-REM sleep, as we all know, and there are various etiologies. You can get it as a variant of Selex, which is, as we've discussed, the new Bex. You can get it with Soleus, which is the new Paniatopoulos. And you can get it with genetic syndromes, and you can also get it with lesional epilepsies. There are various presenting seizure types, but with the evolution, you tend to notice that absence and atonic drops are more common. And you can see that in a paper by Guarini. It's quite an old paper now, but actually you can see that ESES and drop attacks tend to occur with the evolution. So he's not quite right, is he? Seems to have a headache or some unusual feeling, doesn't he? His head. And his awake EEG shows focal discharges, in fact, more on the right side. But when he goes to sleep, you can see on the bottom that he develops generalized spike wave discharges. So once again, does this point to an age-dependent increased excitability and synchronicity of the immature brain? Because you find that once you get to puberty and adolescence, this particular feature subsides, doesn't it? So the Cleveland Clinic looked at 296 video EEG seizures of 76 children. The seizures were classified on the observable behavioral and motor manifestations first, and then the EEGs were looked at. 4 seizure types accounted for 81% of the seizures. The most common was epileptic spasms, then clonic seizures, then tonic, then hypomotor seizures, which are an arrest or a decrease in motor activity with an indeterminate level of consciousness. That would now be awareness. This is just an example I'm going to show you of a young baby. Look carefully. This is an example where it's very difficult to tell what the level of awareness is because of the age of the baby. Seems aware there. And then he doesn't seem so aware there. So very tricky. There were some subtle features of seizures. He had some hypomotor. The video's longer, but in the interest of time, I don't want to play it all. He had some hypomotor phases and some sucking and mouthing movements, but as you can see, it's very difficult to tell whether or not there was preservation of awareness. But he turned out to have a frontal cortical dysplasia. I think most of us at this stage will be putting our money on an absence seizure. So what started off looking like an absence is actually a focal onset seizure, as I'm sure you're aware by the end. But it was difficult when he was having the absence phase to know what his awareness was. So what they found was that focal motor seizures are reliably associated with a focal EEG. And I think we saw that with the earlier presentation. But with increasing age, generalized motor and hypomotor clinical seizures in children may be focal, or they may be generalized on the EEG. Auras and prominent automatisms and classical tonic-clonic seizures are rarely seen under the age of 3. Apnea and bradycardia are also age-specific phenomena seen in younger children in temporal and extratemporal focal onset seizures. And previously, they were found more frequently in neonates with hypomotor seizures, and I'm sure we've all seen those as well. Nordley's group also examined clinical and EEG features of 1,850 partial seizures. I take my hat off to them. In 123 children, distributed by age groups. And what you can see here is that the dark pattern is children over the age of 6. What you can see is that aura, automatisms, dystonic posturing, secondary generalization, all increase with increasing age compared to under the age of 2. And that clonic features and tonic posturing decrease with age. So you get more, again, this points to perhaps more focal patterns of functional connectivity with the more, the features more reminiscent of adult seizure semiology beyond the age of 6. Fogarassi et al. Reviewed videos of 605 seizures selected by seizure freedom after temporal lobectomy. And they demonstrated an age-dependent seizure semiology. And what you can see here is that there's an increasing frequency with age of automatisms, lateralizing signs, secondarily generalized tonic-clonic seizures, which suggests that the semiology of temporal lobe seizures becomes better defined with age, with these features increasing. Conversely, aura, emotional features, autonomic signs were independent of age. Frontal lobe seizures, again, Fogarassi analyzed frontal lobe seizure semiology in 111 seizures for 14 children under the age of 7. The neuroimaging and the ictal seizure suggests frontal focus, and following frontal corticectomy, they became seizure-free. 3 seizure types accounted for 75% of the seizures: tonic, clonic, and spasms. And 95% of them showed motor features. The similarities to adults were that they had daily seizures, they had clustering, they had seizures from sleep, and they were of short duration. The differences were that there was no typical versive movements, no secondary generalized tonic-clonic seizures, and no bimanual or bipedal or other complex motor automatisms. So in summary, semiology changes with age and maturation. The younger the child, the less reliable the semiology becomes for localization, and in fact can be misleading, as we've seen, in terms of lateralization in a couple of the patients. Focal onset seizures may have generalized clinical presentations. Adult patterns of semiology are rarely seen under the age of 6, with auras, prominent automatisms, and classic secondary generalized tonic-clonic seizures rarely seen under the age of 3. And could this be explained by higher excitability and synchronicity of the immature brain, and the shift from a diffuse local functional connectivity in children to much more focal patterns of functional connectivity in adults? Thank you.
Thank you, Professor Anita, for your nice presentation. Now we shift to Professor Dr. Maybe after the, because the time factor. Now we shift to Professor Dr. Maha Awadallah from Ain Shams University. She is consultant pediatric neurologist in the Portland Hospital, London, UK. She will present a topic entitled Sudden Infant Death in Sudden Unexpected Death in epilepsy.